I'm Winnie, and I will be presenting a brief overview of the white paper for you today. So I want to start at the significance of this paper and why we've invited you to be here today. To me, these few quotes here are very telling of this hidden duality in psoriasis, where on one hand, the general public tends to believe or perceive of it as a skin disease solely, but for people who actually live with the condition, their caregivers, their clinicians, they have a different experience altogether. There are broadly 5 sections to the white paper, if you've had a chance to look at it. And we will go into each of them to understand a bit more about the complex health and social needs of individuals living with psoriasis and their families. Before we dive in, I do want to acknowledge that the white paper would not exist without the sharing of lived experiences from all of our participants, especially patient advocates and caregivers, and some of you are here with us today. So psoriasis is, first and foremost, a common and chronic disease. It's estimated by the Global Psoriasis Atlas that about 90,000 to 500,000 of Malaysians have psoriasis. So at a basic level, what is happening is that the immune system is triggered to cause this abnormal inflammation in skin cells and other parts of the body. But this happens over a lifetime. It is lifelong, which means that comorbidities and consequences on daily life, if that inflammation is not well managed, all of this is part of the life of someone who lives with psoriasis. And why this is particularly severe from a societal point of view is that the majority of onset is before the age of 40. So this repeated cycle of flaring up with symptoms, bringing it down to perhaps 50% with treatment over weeks and months, and then repeating that again and again is very disruptive and distressing, as I'm sure you can imagine if you don't have psoriasis. So not forgetting also that about 1 in 4 people with psoriasis will develop joint problems due to psoriatic arthritis, which makes it very difficult to perform simple tasks like walking, turning the doorknob, and even cause permanent deformities. And it was not that long ago, only in 2014, did the Global World Health Assembly formally recognize psoriasis as a non-communicable and disabling disease. The next section, this section focuses on the invisible burden of disease. And one common way of measuring psoriasis in clinics is the size of the lesion. So 1% of body surface area is roughly equivalent to the size of your hand. But we know that this visual assessment does not actually reflect the full impact on patients. So 1 in 3 patients in the Malaysian Psoriasis Registry reported very large or extremely large impact that their skin condition has caused on their quality of life. And I think we can imagine as well, when it involves sensitive areas like the face or the hands, or being of younger age, or someone who has higher levels of depression, anxiety, and stress, all of this leads to lower quality of life as a direct consequence of disease that may not be well managed. And disturbingly, people living with psoriasis are more likely to have depression and attempt or complete suicide. And this was highlighted with much concern by our participants who know some of their members who have, for example, taken their own lives. The Dermatology Life Quality Index is a tool which is used in clinics, but it is not a mental health screening tool, so it may not be picking up these cases. We heard many experiences of social isolation and exclusion over the years our participants were living with psoriasis, and they described how it was difficult to get the support that they needed, the stigma from others, including their family circles, employers, education providers, who often had little awareness of what the condition was, and having to seek diagnosis and seeing doctors at the age when people around you are focusing on their career, education, their family, and how absolutely heartbreaking it was to hear that there is no cure for this condition. And I think much of these invisible battles actually exist outside of the awareness of policymakers and the general public, because these are not captured in the form of data. And when we look at the data that we do have, we can see that it is really the tip of the iceberg. So globally, about 2 out of 3 people with psoriasis have a mild form of the disease. But when you compare the proportion to our national registry, you can see that our data leans towards more severe cases. And this is because the registry is mostly contributed to by public hospitals and doesn't have much data from primary care and most private hospitals. So for many patients, we do not actually know what their care looks like. Yet even for these moderate to severe cases, of which we do have some data, the treatment outcomes at follow-up shows that some did not improve and some even worsened. So there are challenges and they continue to experience the same problems. One point that was very consistent throughout the series of consultations that we did was that effective treatment plays an important role in lifting the burden of psoriasis. So it not only controls symptoms, discomfort, and pain, it also has these ripple effect or ramifications on the activities of daily living, livelihoods and opportunities, as well as mental health. And a good place to start talking about this a little is the different management approaches between public and private healthcare sectors. And I won't go too much in depth here. We do have a panel discussion later with Dr. Muniza, but you can see the Malaysian clinical practice guidelines on the right-hand side of the table. This is in the process of being updated. So it has these severity levels to guide the selection of treatment. Of course, it is individualized by the clinician to the patient, but in general, if less than 10% of your body surface area is affected, you would be recommended to start with topical treatment and then slowly move up. Whereas for more extensively affected patients, a dermatologist may suggest phototherapy or systemic oral treatment. And if these fail, then the very last line would be biologics, which is conditional and it's limited. So on the right-hand side, you can see a diagram from the registry pointing out that topical treatment is mostly used and biologics and phototherapy are least used. Whereas in the private sector, where perhaps resources are not as constrained, the approach is more aligned to international guidelines, whereby oral or biologic treatment is recommended if you fulfill any of these criteria. And if you look at the table for the US and the UK, the threshold of 10% is used to describe severe psoriasis rather than the 30% that we are using. It's important at this point to mention, to raise the topic of treatment goals, which for many would be skin that is clear of psoriasis or mostly clear of psoriasis. And this was not previously possible, but it has been made possible with the development of biologic therapy that targets specific inflammatory pathways and even leading to a 90% reduction in symptoms. So previously, I think the range of treatment achieved 50 to 75% reduction in symptoms. But the issue is, I'm sure many of you are aware, is limited financing. So currently the public sector relies on making applications to Tabung Bantuan Perubatan, Zakat, Public Service Department, and other ministries to actually get treatment to some of their patients. Whereas for the private sector, unless you have a very specific kind of insurance, you are most likely going to pay out of pocket. It was remarked during one of our meetings that the current state of treatment has actually led some members of the psoriasis community to turn to alternative medicine because of the dissatisfaction and frustration with the treatment that is available. So our esteemed panelists will discuss further some of these challenges and gaps in the upcoming discussion. And I will just go through some of the main points here. So when it comes to seeking diagnosis, there are instances of health professionals not being aware of psoriasis as a systemic chronic condition, and therefore this affected the treatment that they recommended or the speed of referrals that they make to, for example, tertiary care. There is concern that the link with comorbidities is being missed because it is seen as a cosmetic or skin problem. Some of our participants experienced delays in GP clinics and private hospitals, but the public healthcare service was generally perceived to have reliable diagnostic pathways. On the flip side, treatment options are limited or more limited in the public sector. And it's not surprising since the majority of patients do seek care there. So for moderate to severe psoriasis patients, topical treatment is supportive and you need systemic treatment or phototherapy. But the coverage of biologic therapy as one of these options are extremely limited, and it may only be enough for the very severe of cases. So the availability of treatment, therefore, does constrain treatment goals for patients and clinicians alike, leading to low satisfaction because the person living with psoriasis still cannot really live or work with the quality of life that they may have hoped for. And stigma is another factor where even if the person receives treatment, employers discriminate because of them having a visible skin disease, or because they are unable to understand the functional limitations that come from the disease itself or medication side effects. Now we know that not all patients will seek care in the public sector, and some will go to the private, and yet private health insurance does not consistently cover psoriasis, perhaps not being aware that it is a chronic condition with a similar quality of life to that of diabetes and heart disease, and also having that cardiovascular comorbidity. So what this means is it results in a greater burden on our public healthcare system. For psoriatic arthritis, there is slightly more recognition, perhaps due to the visible physical impairment that they face. And lastly, for this slide, the National Registry is definitely a commendable effort, but it remains to be seen how the findings are used constructively in patient care. And some of our participants commented that they had no idea of the significance of the research to them, perhaps not, despite them being the study subjects, they were really unsure what the registry was for. And finally, to wrap up, we make 5 recommendations in the white paper. So the first, I think the most important, is to support and empower people living with psoriasis and their families, because they are not just recipients of care, but they're important in shaping shaping the provision and the evaluation of the care that we provide. And secondly is to implement a national psoriasis program, which will enable treatment goals to be followed through and include a multidisciplinary team that includes mental health professionals and pharmacists as part of the team. Thirdly is to improve access. The availability of interventions and therapies should be responsive to the actual health needs of the population, so that people with psoriasis are able to receive that optimal care, including if they need innovative therapies. Many in the community rely on the public health system. It is a long-term disease, therefore there are long-term costs, and therefore funding should be harmonized to look at some of these existing gaps. The fourth is a recommendation to classify psoriasis as a critical illness, so that schemes like My Salam, EPF, and SOXO can provide that much needed safety net. And providing private healthcare insurance is crucial because it is recurrent and you need to manage this condition over the long term. And to wrap up, the National Registry has this potential to promote capacity building in terms of optimal treatment and care.